MDs on staff. We have about a quarter time of ARNPs that provide psychiatric med management. We have one PhD level counselor, and we have two master's level counselors that provide services as volunteers. We also have two SUDPs that's new to our team. We were having trouble accessing substance use assessments that people need in order to get into inpatient treatment, and so we hired a couple of SUDPs so that we could expedite the process. In addition to the medical staff that you see listed, we also have 5 certified peer counselors who do outreach and intensive case management. We have a dedicated transport team to take people to substance use and behavioral health treatment outside the area. We have team coordinators and schedulers. We have an ACA navigator on staff, and we'll soon have a second ACA navigator. And we have 2 FTE for administration of programs. Next slide, please. Our medical and counseling clinic focuses on reducing inappropriate use of emergency services, including the emergency department. In 2022, 73% of the people who received services in clinic said that they would have used the emergency department if not for Olympic Peninsula Community Clinic. We provide care for members who cannot find or afford a doctor or a counselor. There are many community members right now who are struggling establishing primary care, and we offer bridge services for them while they are waiting for their first appointment with their new provider. We'll provide bridge services, necessary prescription services, and make sure that they remain as healthy as possible until they're able to be seen by their new physician. We also do Affordable Care Act signups, and for those who are eligible for private insurance, then we refer them to an insurance agent to complete that sign up. All we are able to do is sign people up for Medicaid. We also operate the Breast and Cervical Health Program. It used to be called BCCHP, but they no longer provide colon health services. The Breast and Cervical Health Program has been operating in our clinic since 2013. It provides services to community members who need cancer screenings and don't have or qualify for insurance. It also provides cancer care for those who have tested positive and can't afford the care themselves. Our clinic is primarily volunteer. We have 0.2 paid FTE on staff. All of our other providers are volunteers. We still are the volunteers in medicine. And we provide both in-clinic services and street and shelter medicine services. So we take care to people wherever they may be. One night a week, we have a team up at Serenity House. We have 1 MD, 1 ARNP, and 2 intensive case managers who go. We occasionally also have medical assistants or nurses join our team. Each week we see approximately 25 to 35 patients in that evening clinic. And we need a medical director. Dr. Gerald Steffens has been our medical director for the last 5 years. He retired at the end of December, and we now have an interim medical director, but we are looking for a permanent medical director. So if anyone knows a retired or retiring physician who wants to stay active, I'd love to speak with them. Next slide, please. We also provide not just appointment services, but we did a lot of work during COVID, providing COVID tests, COVID vaccinations, and care for people who had COVID. In addition to our 1,200 visits in clinic and 1,300 street and shelter medicine visits, we did more than 1,300 COVID tests. The bulk of those were at congregate living facilities. And then for those people who tested positive and didn't have a physician, provided care for them. We provide vaccines through the Washington State Adult Vaccine Program, and we purchase flu shots for those who are unlikely to go and get a flu shot. We take them to our street and shelter clinics and provide them on site for people. In all last year, we had 1,910 volunteer hours, nearly a full-time person as a volunteer. And those are just in-clinic hours. We know that some of our volunteers logged many more hours as volunteers than they put into their volunteer logbook. We provided services to 294 unique patients in clinic. It's a little harder for us to measure how many people we served outside the clinic, because when we take medical care out on the streets, sometimes people will come to us and they don't want to give us their name. They just need to have a wound looked at, or they need to have a medication that we provide. And we also have medications that are provided through AmeriCares and Direct Relief that we're able to dispense to patients. And so we provide care regardless of a person's willingness to tell us their name and identifying information. We certainly encourage them to, but we know that we saw at least 400 different people outside the clinic. The 4,000 patient encounters last year makes us the third or fourth largest free and charitable clinic in Washington State. The others that are our size or larger are in Seattle or the Portland metro area. So for a rural nonprofit, we see a lot of patients. Next slide, please. One new component of our medical services is the Clallam County Homeless Medical Respite Program. This is a 2-year pilot program being operated in conjunction with Clallam County Health and Human Services, North Olympic Healthcare Network, and Serenity House. And it's located at Serenity House. We have rented 4 rooms in an isolated portion of the Serenity House shelter, and we operate a full-time respite program there. This is provided for people who need a home-like environment to recover from specific medical conditions. Only those who are referred into the program by a physician may enter the medical respite program. You can't just opt in, you have to be referred in by a physician. We officially launched in October. And I just got statistics today for our first couple of months. We've had 8 patients. 72% of them were chronically homeless. 25% of them are veterans. And among those 8 patients, the emergency room visits decreased by 23% when they entered the respite program. That's 30 ER visits averted by having the medical respite available for them. Right now, we are accepting referrals primarily from OMC, and our focus is to try to provide an outlet for those where a respite-like environment is an appropriate discharge. And we're still kind of working out what exactly that looks like, and we're very small capacity, but to the extent possible, if we can help to offload some of the load here, then that's our primary goal. Next slide, please. As I mentioned, we also have a dental clinic. Right now, our dental clinic is receiving new equipment. We provide services like in our medical clinic for those who cannot find or afford dental care. We see a lot of Medicare patients because of the lack of a dental component to Medicare. We expect to reopen with our new equipment later this month. We are getting a new panoramic x-ray, a new x-ray head for one of our rooms that didn't previously have that capacity, and 2 heavy lift chairs to better accommodate some of our patients. Last year, we provided triage and refer services for more than 600 patients, and we expect that we will see far more than that this year. Next slide, please. OMC's community relationship goal number 5 calls for engagement with key partners and stakeholders, including rediscovery. So tonight, I want to talk to you a little bit more in detail about what rediscovery is and who you're partnering with when you partner with rediscovery. I mentioned Dr. Jerry Steffens recently retired as our medical director. When he first became medical director in 2016, he sat down with me and said, "We're not meeting the people. They're not finding us here in our clinic. We need to do something different." And so we started looking at different ways that we could reach out to those in our community who are underserved. And we started going out on the streets, meeting people at friendship dinners, going up to the shelter, and meeting people where they are. This uncovered a lot more need than we were aware of, and different types of need. And so we launched a new program with a social worker. Many of you know Amy Miller. She launched our rediscovery program, going out with Port Angeles Police Department to meet with people who are in crisis and begin providing services. The Rediscovery Alternative Response Team programs provide an outlet for non-arrest outcomes. There are people who say that we are stopping arrests. Well, we're not stopping appropriate arrests. What we're doing is providing services so that hopefully people in the future will not be arrested. Our focus with these programs is to decrease the overuse or misuse of emergency services, and that includes the emergency department here. It includes fire paramedics and police response, DCR response, and others. And ultimately, our goal is to create a safer, more vibrant community. The biggest funder of rediscovery programs is the Washington Association of Sheriffs and Police Chiefs, or WASPC. And their program manager, Stephen Briggs, provided a statement that he asked me to read tonight. WASPC is happy to say that the work done by the rediscovery team perfectly aligns with what we expect from programs that receive funding under WASPC. Programs like Rediscovery help create better human and societal outcomes for community members with complex behavioral health and substance use related needs. Partnerships like those formed by Rediscovery are also instrumental in creating safer communities because they directly address some of the root causes of continued involvement with law enforcement. And when we talk about partnering with OMC, that's exactly what we are looking for. Creating safer communities by directly addressing some of these root causes. Rediscovery is made up of many different sub-programs, if you will. Next slide, please. Our first program was the Mental Health Field Response Program, where we would meet with people in crisis. We would go out and co-respond with police or be dispatched by police to meet with people and provide in-the-moment services. What we found as we started providing these services is that a 5, 10, or 20-minute encounter ultimately didn't solve people's problems, that we needed something more. And so we began to engage a little bit more deeply, provide follow-on services, provide referrals to service. And that led us to expand our program. Next slide, please. To an intensive case management program called Arrest and Jail Alternatives. This provides ongoing care for those who need that intensive level of support. We meet people where they are, and all of our services are participant-led, so we may be working with someone for a very long time, in some cases years. And as we're doing that, we work with them to make and pursue goals that, in the end, provide for a better health outcome. And better health outcomes include things like not being arrested or having fewer interactions with law enforcement. As I mentioned, these services aren't time limited. We have as many as 600 encounters with one of our long-term participants, and in doing so, have been able to work with that participant to find housing, to find a job, and create some stability that is leading to better outcomes. Next slide, please. For those who have been arrested and are residing in Clallam County Jail, we have a Medications for Opioid Use Disorder program. This program provides startup and continuing medications for people in jail who have or have had opioid use disorder. When we started this program, the jail told us, we think that you'll probably be serving 3 or 4 people at a time, maybe 20 in the first year. What we found is that need and desire for these services was vastly understated. In the first 3 months of the program, we weren't sure exactly which data to capture, so we really just tracked how many people were released from jail into treatment, and we already had 9 in the first 3 months. We began tracking things a little bit more regularly, and by the end of December, we had served 75 individuals in the jail and 41 assessments, those SUDP assessments that are necessary to enter inpatient treatment. And we transported 21 people to treatment. Now, these transports are out of area. One thing that we've found is that there just is not enough capacity in Clallam County to provide the intensive treatments necessary. And so we will quite often send people to Everett or Tacoma or Yakima or even Spokane. And we have a transport team that goes with them, makes sure that the intake is successful, that they are settled into their program, and we found that this provides much better outcomes. Next slide, please. This month, we started a brand new program called Lead Fire. LEAD, or Law Enforcement Assisted Diversion, is a program that started in Seattle in 2011 and has spread nationwide and now even worldwide. It is a pinnacle model for organizations that provide intensive services to people in lieu of arrest. And we have LEAD-like programs in rediscovery, our Arrest and Jail Alternatives program, and our unfunded, underfunded behavioral health program that I'll talk about in just a minute are both LEAD-like. But this year we started Lead Fire, which is the first of the 1,100 LEAD sites to be affiliated with an agency that is not law enforcement or criminal justice. we were able to work with the lead national bureau to show that when Rediscovery and Port Angeles Police had been talking about participants that enter our programs, the paramedics that are also a part of our care team said, oh, well, we've been working with them for a few years, and yes, we know them. And so we thought we'd move upstream just a little bit and start providing services to people who frequently encounter the fire paramedics and who are exhibiting behaviors that we see over time lead to increased use of emergency services, inappropriate utilization of the emergency department, and ultimately behaviors that can and often do end in arrest. By providing these services earlier, and again, we're just launching this program, but our pilot last year showed some pretty dramatic results in averting behaviors, providing services, and linking people to necessary services. Next slide, please. Our unfunded, underfunded behavioral health care program is another LEAD-like program that provides intensive services to people and also funds one of our SUDPs to attend the syringe services program or needle exchange in Port Angeles and Forks. So for people who are going to the exchange, who are ready to make a commitment to treatment, we have a substance use disorder professional right there who can provide an in-the-moment assessment and start moving toward treatment for people who are ready. Next slide, please. In 2022, Rediscovery provided services to 696 fully identified individuals. Like our medical team that goes out on the street, we also provide services to people who don't want to give us their full name. There were 319 who gave us a first name, and 198 who wouldn't give us a name but received some level of service from us. Sometimes that was just a bus pass, sometimes it was food, sometimes it was just coming in to have a cup of coffee and get out of the rain. In all, we had 6,996 encounters and provided 2,334 referrals to service. For us, a referral is more than just information. We have to provide information about a service, a way of contacting the service, and for those who need assistance, transport to the service. From those 2,334 referrals, we had 1,899 connections to service. That's an 81.4% connection rate in an industry where 30% is considered exemplary. The way that we provide referrals and access to services is a model across Washington State, and our programs have also been used for models in El Paso, Texas, Athens, Georgia, and I can't remember the small town in Vermont that is using our model to establish their program. As I mentioned, we had 75 participants in our MOUD program, 21 of those transported to treatment, and 9 others received treatment locally for a total of 30 participants who entered treatment just this year. We also had 24 individuals who finally received housing. There's a housing crisis in Clallam County. We have experts on our staff who work with participants to find and access housing. And for those 24 individuals, what we found, once a person has a place to stay and are no longer living in public, then not only is the shelter more healthy, but there are things that we do at home that we just take for granted that if we were living in public, then would lead to a call to police or some encounter that potentially has a worse outcome. We do everything that we can to find housing, temporary, transitional, or ideally permanent for everyone that we're working with. So that's a general overview of our medical, behavioral, dental, and outreach programs. And I hope I left enough time for any questions from the commissioners.
Scott, I have a couple questions. Actually, where does all your funding come from? How many from grants, donations, etc.?
Right now, 96% of our income comes from grants. 4% comes from donations, principally local. Our biggest funder is Washington Association of Sheriffs and Police Chiefs. Part of that is passed through City of Port Angeles. Our next largest funder is Clallam County.
And what do you use the money that the hospital contributes?
We receive money from the hospital for our dental program and also for our what's called combined services program, medical and behavioral health programs. So that provides staff for the front office and gives us a little bit of money for medications, principally immunizations.
Okay, all right. I just want to congratulate you. I sat on that board for a while, and I compliment you on the progress that you've made and the improvements and just the overall success. It was a real question here if they would even make it through. And I know Dr. Hoffner and his wife and Mary Sherwood would be just very proud to see this and all it's going. So thank you.
Well, thank you very much. I might also mention that we have achieved financial stability, so.
I want to thank you for the work that you're doing, and are you aware that what Elevate PA is going to do right now? They're adding additional security downtown, and I don't know how that's going to impact the number of patients you might need to serve or not. You just should be aware of that.
I appreciate that. One thing that we find is that as people move from the places that they are now, they find other places, and we are typically able to locate them and provide services almost wherever they are. Thank you. We'll keep an eye out for people moving to different areas.
I have to say, Scott's being a little modest this evening because this program has a national reputation. In a small rural area, this is doing things which larger programs and in some urban areas don't do as much of. So Scott, I want to thank you. You have a team that is spectacular in what they do, and they give and they give and they continue to give, and you support them in that giving. So one of the reasons I wanted to have this presentation was to begin letting the community know the scope of services and how the lives that you're touching every day is making a difference. So thank you very much.
Thank you, Tom. I'm awfully proud of our team and what they've been able to do. And as Tom mentioned, our team has been used as a model across the state and the country. We have incredible people on our team, and they just won't give up.
I want to thank you for all that you do for our community. As a member of the Strategic Planning Committee, I want to thank you for that linkage. You are an admirable partner. And I also want to thank you for reaching out to our veterans.
Thank you. Yes, that's one of our keys is working with veterans. And as I mentioned with our respite program, already 25% are veterans. We also coordinate with Sarge's Place and with Serenity House to make sure that those veterans who aren't able to receive care through the local VA or access services across the water are able to be served by our clinic.
Thank you.
Any other questions, comments?
Thanks, Scott. It was great.
Thank you very
Scott,
much.
thank you. Thank you very much. All righty. Next on the agenda is Quality and Safety Report, Ryan Combs.
Thank you and good evening. I'm here to discuss a new process we have implemented across the OMC system, which is a daily safety huddle. And you go to the next slide for me. Thank you. So we have a daily meeting to identify safety concerns and promote situational awareness and build teamwork. We keep the meeting short. The goal is 15 minutes or less. It's 100% virtual. We have every day, we have certain departments we do want to hear from every day. But all department leadership is invited, and if they have something of concern that particular day, they're more than welcome to contribute or identify any safety concerns. Next slide, please. Really the purpose here, and I won't read those words, but we just want to normalize the topic of safety and the discussion of safety and make it just part of what we do every day. So this is one step to do that. What we see in the meetings as they play out, and to me it's very fascinating to watch, is again, just the general awareness. I've already heard from departments, I thought I had it bad until I heard the ICU speak every morning, as an example. So it really starts to bring awareness. Pick on Lorraine. I heard Lorraine one day said, "I really like to know what's going on in this hospital." I think you found this as a way to get at least a summary of what's happening. We try to address safety issues in close to real time. Obviously, it's not always in real time, but it's as quickly as we can. And for me, the magic in this is to watch the collaboration across departments. Of somebody struggling, other departments kind of rally around those groups and those departments and offer resources. Next slide, please. So we started this on the 2nd of January. I warned everyone, I thought it was going to be a really bumpy process. Other than WebEx, it really hasn't been. It's been pretty smooth. We had a few WebEx issues which we worked through, but sorry, Mike. But those are streamlined, and actually it's going very smooth. I've led the meetings to date, but we will quickly start to rotate it to other leaders, alt members, department managers, and have as many people as possible actually lead the huddle. Next slide, please. This is an example of the daily groups we want to hear from. As the huddle leader, I'll ask for critical safety issues or a safety moment for the day. We hear from the patient safety department, emergency preparedness, the house supervisor, infection prevention, and case management. Next slide, please. Then the other standing departments are on the next page. I won't go through all those. Again, we're looking for safety events, employee injuries since the last huddle, any risks or challenges that we've addressed in the past 24 hours or we anticipate in the next 24 hours. Patients of concern. To date, a lot of this has been about boarders or difficult to discharge patients. A lot of discussion around that. Any other critical issues that departments are facing, and then we try and follow up and close any previous safety issues. Next slide, please. And that is the actual document we use every day. It is recorded. We keep track of it. Probably don't have enough data and information in there to really start to trend anything, but we're building towards that as we work through the huddles. And with that, I think that's all I have, and happy to take any questions.
Ryan, thank you. In the airline industry or in pilots, they talk about situational awareness, and that is being aware of everything in this vicinity. And this kind of system or process has really got to increase, so everybody has an awareness of what the whole's going on throughout the organization, rather than being focused on their little chunk of the territory. And so I've heard of these kind of systems in other hospitals before, and I'm pleased, very pleased that this has started, and I'm glad to hear that it's already started out with some good steps, and I support this, and look forward to hearing more about this as we go forward.
Absolutely, and I think our next step will be to take it a level further and really have every meeting at OMC start with the safety moment. And just, again, at every level, trying to normalize that it's okay to talk about. We need to surface it quickly and start to address it.
So I talked with one employee probably a few months ago, and I asked her about safety and safety within the organization and that. And she said that culturally she felt that our organization had to operate with an environment without fear, and that at that point a few months ago, she felt that didn't exist. And so how do you feel you're progressing in that regard? And I understand it's early.
Yeah, it's early and I've only been here 3 months, so I don't have a great historical picture, but from what I've seen so far, just in conversations with my direct reports, the comfort level is increasing, that it's not about being punitive. It's not
Right.
about the person necessarily, it's more about the process. What in the process do we need to fix to prevent this from happening again? And I think we just gotta keep talking about it. And again, normalize it. If it seems small, that's okay, bring it up. You know, we can prevent it before it becomes a large issue. And so I feel it relaxing, and leave it to others to comment from their perspective, but.
Well, and being new, some years ago, it used to be a pretty common, it was a common practice of the board to do quarterly every 3-month safety rounds. And so at some point where we can reinstitute the board safety rounds, it would be nice to reinstitute, dovetail that in with this kind of process.
Sure. Absolutely.
Just curious, you say 50 minutes and you look at all these departments and the topics and everything, you can do that? in
Yeah,
50
it's
minutes?
this, yeah, and we stay pretty focused on, this is a brief, this is not a meeting. You know, the departments are pretty structured, they can get through their information in 30 to 45 seconds. If there is an issue that can't be addressed in the huddle, that becomes a separate meeting, and we'll pull those affected folks out to not involve everyone. But it's impressive. We had, I think it was last Monday or Tuesday, materials management mentioned they had an issue with a certain piece of equipment for surgery. I think it was a laser, but I can't remember the exact piece of equipment. Well, the surgery manager heard that for the first time on that call, knowing that on that Thursday they had a patient that needed that piece of equipment. So in real time, they were able to address it so the patient was not postponed for their needed treatment. So it is pretty profound when you see it happen.
Good job.
Outstanding.
Thank you.
Outstanding.
I see this as being just incredibly beneficial for our organization. So thank you for your efforts to get this
You bet.
going.
Absolutely.
Yeah, I would say to those points, I mean, I think I've been listening to near most of these, and I think after every one, I think there's a lot of smaller things that take place.
Yes.
But I think you said the situational awareness, you know, so they're quick. And I appreciate Brian bringing forward, and they, you know, almost always it's like, wow, that was less than 15 minutes, and I'm shocked because but I'm always the one that wants to muck it up. I'm like, wait a minute, what about? But I hold back. I try to just let him do it, and I don't ask questions about details. I'll get to that later, but they're going well, and I in terms of the fear of retaliation, or I think that's kind of what you're insinuating. I would say that it doesn't take place in those. I think the communication is very open. In my that's my impression. I don't know, Vicky or Josh or Lorraine. It's pretty open. I mean, everyone's there just to help each other out, and if someone's having a hard time, you know, let's talk about it. And I think it's been really, really great. So I'm glad Ryan brought it here because I think it's been great.
And from my perspective, Bill, this organization has been under such stress with COVID for 3 years. I would not doubt that there's been some wearing off of some of the values that we're trying to move forward. And so that just reminds us that we need to keep focusing on that. And Ryan, if this is an example of your leadership in your new role, I'm very impressed. Thank you very much.
Daryl, as somebody who used to walk these halls as a staff member, it was always our culture that there are not people problems, there are systems problems. And although one person's perception is their reality, I feel confident that our staff is able to provide blame-free reporting.
Yeah.
Okay.
Thank you.
Thank you, Ryan. Very good. We're at the part of the meeting where any public comment, anyone in the room or online? Any public comment? No one online? All righty. That being said, old business. Any old business? Being none? Daryl, administrator's report.
Okay. And we're gonna defer that, so you know.
Okay.
Okay, just a few slides here. The agenda looked pretty packed, so I was just gonna hit the high points. Let's see. I was gonna try to be independent and do it myself. But, okay. What in the heck? I fixed it, Mike. It's all good now. Okay. First thing I want to do is I want to thank John Nutter for 2 years as the president. They've been 2 really easy years, so I'm not sure why you don't want to do it a third. No, I'm just kidding. It's been 2 tough years. I took this job in 2020, and Jim Lescanovich was president at that time. And Jim, I appreciated Jim very much, and he was really good for that first 6 months because he was good at saying, here are the guardrails. And he would make sure I stayed within them. And so he kind of gave me a little bit of the lay of the land. But what I've appreciated about John is John, in the last couple of years, we've dealt with a lot of new things that we've never dealt with in the past. And I appreciate not only John as president, but all of you. We've had to do some things that have been very hard. I would say painful, and they're not over yet. But John was usually often the first to know because I was talking to him on a weekly basis, and everyone got to know eventually. But I appreciated John being just a sounding board, as we went into some crazy things, and so I just want to thank him for two hard years, but very good years, and I appreciate it very much. And John, you actually get the coveted pen set. I'll bring that over to you when I come back. And I look forward to working with Tom, and all of you in the future. And Tom, you and I will get to spend more time together. But I look forward to that, and we'll continue to do our best and deal with challenges as they come, because I guarantee there will be more. I thought we might cruise this year, but you'll find out that's not happening. So I want to first thank John. I want to thank Scott Brandon too. That was great. It's been a long time coming to have him and others come to these meetings, so it's nice to hear something else besides us speak. And I think hopefully that's first in a series of getting some of our community partners back here to present to us, because I think that's very helpful. Okay, the state legislative session. I talked about this a little bit last time, and the main update I wanted to provide you is we are in it, and we're in it thick now. And I'm going to be pushing out some information to the board. What you do with it is up to you. One of the new strategies that's been deployed, led mainly by the State Hospital Association, is us logging in and making comments around bills as they move through the process. The most recent one was Senate Bill 5236, which was around nurse staffing. It's very similar to the one that was presented last year, around which talks a lot about ratios and some other difficult things that will be very difficult to implement and not restrict the capacity of facilities. So I think that's going to be part of our strategy going forward. How you respond is up to you. I don't get to tell you how to do that. I'm willing to give you my opinions and let you know how it might affect the Olympic Medical Center. But I think that's part of how one new strategy that we're going to deploy. Same will go to alt members and a lot of other staff that choose to be involved in this. But that's a way to kind of send a message early on in the process. Hey, here's who's thinking about this. He often has your name, it might have your affiliation, but it also gives them a sense of who's pro and who's con. And in the Senate Labor Commerce Committee meeting yesterday morning, which is the one I sent you guys, 900 people wrote in as a con, right? And in the past, that would have not happened. Generally, it was the pros that are really pushing this. So all of us engaging, I think, will help us send a message more early in the process about, to our legislators about how we feel about these things. One of the biggest challenges that I see, despite the ratios, which we've talked about quite a bit, is, the enforcement mechanism in the bill that's presented is to L&I. Now, L&I, their sole focus is on workers, and that's fine. That's their job. This bill with nurse ratios, they're not going to be too concerned on how it impacts patients. That's our jobs. And so I see the L&I as being a difficult piece of what's being proposed so far. Anyway, all that aside, I will be informing you all on how you can be involved in this. And I also learned last week that Olympia is going to be restricted on how much access we're going to get. In years past, I know Eric and Jennifer and Bobby and others would run down to Olympia almost every week, and it was open. Not open season. That's the wrong way to put it. Open. The halls were open for discussions. That is not the case. It's going to be similar to our DC trips where you have to be escorted in and you have to go through maybe not x-rays, but there's going to be some restrictions. So some of the events where in the past we'd like to take 4 or 5 people, we may only be able to take 1. And I'm working with Vicki Swanson and others on the whole team. You know, sometimes the best person to send is a nurse who thinks nurse ratios are a bad idea, and maybe not me. Or maybe Bobby about something and not me, or maybe Anne Marie and not, you know, so just please be flexible with us, knowing that we're pretty limited on how many folks we're going to be able to send. And I know a lot of people want to get involved with advocacy. I want to grow the advocacy team to have more, to include more board members, more staff, and more alt members as well. So that's the goal. But it may take a little longer than I thought to actually get you in those situations where you can actually have that experience. But we'll look for those going forward. So the big things that we want to make sure we pay attention to in this session, I talked about nurse staffing, Medicaid funding. Obviously, we all know Medicaid pays us about 65 cents on the dollar for the care that we provide. Difficult to discharge patients. Our case manager, Isaac Ballou, is already engaged with our legislators on some of the challenges around that. So we've got a really good group of folks that can speak well to these issues, and so we'll keep an eye on those. And I want to talk about that, and also just on the tail of this is last time I talked about the hospital's losses in the first 3 quarters of 2022 on the aggregate of the state. So all of these things, and we start talking about nurse staffing, difficult to discharge, you know, it's compounded by the losses. And so I think those all kind of go together as we work through the session. So it's a long session. So we're going to be at it through April or into April, and we'll keep an eye on it. But I'm going to ask all of you to participate. That would be great, as you wish. Okay. So I'll talk a little about operations. So many of you, I've shared with many of you kind of our status recently. The last several weeks, you know, we've been at capacity. There was last Thursday at 4 o'clock, we had 50 people in the ER. As a reminder, we had 20 rooms. At the same time, med-surg was full. We couldn't transfer people out. ICU was essentially full. We tried to keep 1 open bed in the event of a really dire thing. We were there, and so over the weekend, actually, the incident command was stood up. We're actually meeting through the weekend. I was actually out of town. But basically trying to decide what other things do we do. The only real lever that we have to pull is to go back to what we did in previous surges and be looking at what are the elective surgery cases that need a bed after the procedure. Is that, you know, maybe, so we started looking at that going into this week. We did not need to do that, but that's really our last lever in those situations. And the way things are shaping up with the way the winter has gone thus far, and we're not out of it yet, we're going to probably continue to be evaluating things like that. And I'll keep you updated as, you know, if we have a day where we're going to need to be postponing, because we're not canceling, we're just postponing care that's deemed as able to be postponed. But not a good situation, and we're not alone. Most hospitals are in the same situation. As many as 13 facilities in the state have been on divert at any given time. That's Harborview. Those are the people that we tend to rely on. So we've kind of been, as Dr. Kennedy would say, surfing the edge is what he'd like to say. So anyway, I wanted to share that with you. So we've been hard at it. And the staff are doing their best, but it's been really tough. And Dr. Kennedy could not be here tonight, so I just want to give a quick update on the emergency department transition. I just talked about the capacity issues, but at this point, they have 4 signed providers. They have 2 more verbal agreed providers, so that's 6. I'm looking for a total of around 12. So we're looking, is that right? Or is it 15? maybe I'm misspeaking. 12. So we're looking at about half of the bench being filled. I mean, some are starting this month, some are starting February, some are starting in June. So it looks like the bench is about half full. There's several more that are just not confirmed. There's a lot we haven't met yet. So a lot of good providers coming through the sound system, and then if they get through that system, then we're talking to them. And if they check out with us, then we're moving forward. So we have several providers that have been interviewed and we're working with, or they're working with on contracting. And we have several more that are coming to interview. So that, while I wish it was all done already and it was all perfect, it's not, but we are making progress. And so I think that's good news. Anything else for anyone on that stuff? I just covered for Scott on that, but. And then I want to talk a little bit about management reporting, some changes. I've been hesitant to change the org chart until the election tonight, so I haven't done that yet. But now that that is done, we're going to make some changes, and I want to explain those quickly. So we all know Ryan. Ryan is going to be taking over direct reporting responsibility over the lab and imaging services, as well as Julie Black's division of support services. And you'll see a proposed org chart before we do all this, but I just want you to know this is sort of how the structure is starting to form. And then Vicki Swanson will be education department, report to her. Patient experience, we heard from Sophia earlier. She's going to be working with our quality and safety program, which is overseen by Dr. Kennedy. HR, risk, compliance, and marketing will continue to report to me for the time being, but we'll continue to work on those things. So there's gonna be some changes on there, and I've shared some of this with you, I think, in a draft org chart. And I'll be continuing to work on that draft, and now that we know who the president is and the secretary, I'll be bringing those to you guys here soon. But those parts I just mentioned, we're already making those transitions. So I just want you to know that. And the last thing, and it's not on my slide, is we are starting our it's the state accountability audit with the state auditor, and that is beginning later this week. So that's just another task that we have going, and be more to come on that in the future. So that is my report. Happy to answer any questions about those items, or anything else that you have on your mind. And I'll bring John his pen set.
Thank you, Daryl.
You're welcome.
All right. The subject under other, I don't need to make any comment on you can tell. Okay, so
15 minutes.
15, thank you, I would
Yep.
ask you that exact
Yeah,
question.
I knew you
So, we're leading into an executive session. The discussion will, with legal counsel about current and potential litigation.
We have another agenda item.
No,
We're gonna defer that. That's
being-
deferred.
that's
Yep,
being
no
deferred.
problem.
Thank you,
Yep.
thank you, Tom. Under RCW 42.30.110(1)I, we move to executive session.
Are we
What are
taking?
we doing now?
Do you want to take a quick break? Would that be helpful for anyone?
Yeah. You want to take a break? Anyone? We'll give a couple minutes so folks can depart.